what I would actually take you across through is the philosophy involved in the undescended testes, and then the algorithms how to go about treating them. So in a nutshell, this is a whole life, the testicle is a whole life in a nutshell. So we need to be careful about how we tackle this organ. So first and foremost part of the undescended testes is the mechanisms of descent. Now, do we have any specific idea in terms of what are the primary causes of the mal-descent of the testes? Lot of there have been a lot of philosophies or a lot of postulations which have been put in terms of hormonal, where there was a decrease in LH and then a decrease, increase in the decrease in MIS. So a lot of things have been put forward, but none has been actually proven or linked specifically etiologically for the testicular mal-descent. Then came the simpler gubernacular theory. Then the genitofemoral nerve, they said that the genitofemoral nerve acts as an important stimulant for the descent of the testis. They also said the intra-abdominal pressures create the descent. Then the relative growth of the body. The whole rationale came here because most of the children who have a mal-descended testis with lower fertility rates are significantly born small for gestational age. And then there was also a postulation saying that the spermatic vessels would not lengthen, the Y chromosome, the inhibin. So a lot of things have been said in terms of testicular descent, but none of it has been proven that this is the primary etiology for mal-descent. Now, there have been a lot of endocrine tests, endocrine investigations which have been done in terms of trying to find out the etiological cause. People have looked at gonadotropins, people have looked at androgens, they have looked at decrease in the LH, and then also the lack of the LH surge in mini puberty in the first 2 months of life. They also looked at diet of testosterone, they looked at MIS, and also the testicular tissue volume. They said that the tissue volume is smaller, there is a very significant increase in the undescended testis. So then came a bigger thing in terms of environmental factors. So there are a lot of environmental factors, including the endocrine disruptors. Now these come from, where do these environmental factors come from? They come from pesticides. They come from plastics. So they have been attributed, from the plastics you get biphenyls, bisphenols, and then they are attributed to testicular dysgenesis and also decrease in Leydig cell function, androgen insufficiency, hypospadias, testicular mal-descent. They also have looked at decrease in the fertility rates, and they're also increased in anogenital distance. So environmental factors do play a role, but there is no definite evidence that they are the primary disruptors in the testicular mal-descent. So what happens to these children who have testicular mal-descent as far as the fertility is concerned? In a unilateral extra-abdominal testis, the fertility is almost the same as a normal child. And a unilateral intra-abdominal testis, the fertility rates are less, but the paternity rates are normal. That means the fertility rates, the amount of number of spermatogonia and the sperms are less, but ultimately when they look at the percentage of paternity rates to children who had both descended testes, their paternity rates are normal. If there is bilateral intra-abdominal testis, both the fertility and paternity rates are low. And if the bilateral extra-abdominal, again, it turns out like a unilateral intra-abdominal testis. So what happens to these testes? If it's an ipsilateral, intra-abdominal and palpable, what happens to the contralateral descended testis in terms of fertility? And you can see in this graph that the number of germ cells per tubular cross-section compared to that of the normal testis actually are much lower in children who had an ipsilateral intra-abdominal testis. And this is more so in children who are born for small for gestational age. So there are changes in a contralateral descended testis in case of an ipsilateral intra-abdominal testis. Now, they also looked at the hormonal evaluation, and they said that the patients with low basal LH value, and then where the LH does not go up in the mini puberty, there is a significant rate of decrease in fertility in these particular children. And there's been no correlation between the inhibin values and the FSH over a period of time. Now, let us look at retractile testis. The philosophy of retractile testis, as we looked at, was that if the testis is retractile, that means if you can pull the testis down to the base of scrotum, then it is called a retractile testis. And these retractile testis would not need surgery, and probably you can you may not need to follow up these testis, but evidence proves it otherwise. About 10% of retractile testis require surgery. They need to be followed till they descend. Now, what is the age limit? At 12 years. If it doesn't descend by 12 years, they need to be fixed. And if the retractile testis does not stay in the scrotum after examination and ascends to the superficial ring, and these are the children who may really need orthopexy. So we need to take care of these children and then follow them up very carefully. If there is associated hernia or a patent process vaginalis, the ascending testis is a reality. So these testes can ascend even into an intra-abdominal position when the child starts growing. And the volume of a retractile testis, which is above the scrotum, which is lower than the scrotal retractile testis. That means if a testis can be pulled down into the scrotum and stays in the scrotum, the volume is almost the normal as a normal testis. But if it does not, and if it ascends, these are the testes whose volumes are definitely lower compared to the normal testes. Now, what's the acquired cryptorchidism? You have to first document that the child had a normally descended bilateral testis, and they should be documented they have been in the scrotal sac. They should be differentiated from the retractile because these are normally descended testes. This is more common in children born in small for gestational age. It can be about 24%. That means in a child who has been born preterm, you can have about 19 to 24% of these children, when they grow, the testis probably ascends into the groin or into the abdomen. And a family history of undescended testis is an independent risk factors. The ad spermatogonia and germ cells are significantly decreased in these particular type of testes. So if you look at acquired cryptorchidism, and then if you see the number of hernias in the testis, almost about 40 hernias, 140 of these out of total of 289 had hernias. And it could be unilateral or bilateral. So about 1/3 of unilateral and, 2/3 are unilateral, 1/3 are bilateral. So the presence of hernia makes it a very important point that these testes can ascend. Now we all look at that if a testis is in the intra-abdominal position or not in the scrotum, we all know that this testis has a higher risk of malignancy. So the relative risk of a testicular cancer is around 20 to 46 times, and if it is an intra-abdominal testis. And 12% of these would have ITG-SIN, which is the older terminology, now we call it CIS. And the relative risk in a contralateral descended testis is about 1 to 2. That means more than twice a contralateral descended testis can have a tumor if there is a unilateral undescended testis. The location may not affect this pathological type because 80% of these are seminomas. But if the testis is fixed early, 30% could be seminomas, 30% could be embryonal tumors, and then it's almost an equal distribution post-orchiopexy. Does orchiopexy decrease the risk of malignancy? If it is done pre-pubertal, yes, probably 2.2 to 2.35. If not done pre-pubertal, the risk still is quite significantly higher. The risk of malignant degeneration of the remnants is high in terms of streak gonads, but if there is a nubbin or a blind ending vessels, these testes rarely become malignant because only about 2 to 3% of these testes would harbor any kind of germ cells. So the nubbins can be left inside without much of a risk. So to summarize, the history and clinical examination in children are extremely important. You need to look at the ipsilateral and the contralateral size. Now, the contralateral size is important if there's contralateral descended testis has got a bigger or a larger size. So we know that the opposite side testis is smaller for age and smaller in size. We need to look for ectopic areas. We need to, if there is a bilateral testis, and if there is also an anomaly of the urethra or the penis, we need to look at karyotyping. We need to look at HCG testing, imaging in very specific cases. But for us, an imaging of an ultrasound is generally done, but a negative ultrasound would not change our plan of management, but a positive ultrasound would give us some lead to go ahead. And the other thing is it will also probably give us another overview of the anomalies. So the management needs to start at around 6 months because now it rarely descends up to this age. Most of the treatments are to be completed by 12 months. The EAU says the latest by 18 months, but the recommendation now is to complete the management by around the surgical management by 12 months. Medical therapy, the success rate is around 20% and is not recommended. There's no difference between daily or alternate day dosages of HCG. And fewer lower dose injections for 5 weeks seems superior, but definitely not statistically significant. A few papers have told us that the hormonal treatment may improve fertility status by increasing the number of spermatogonia. Not sure. Testicular biopsy may prognosticate the fertility potential in bilateral cases. Offer orchiectomy with normal contralateral testis in post-pubertal children. Fertility in unilateral UDT is lower, but not the paternity rate. And then in bilateral cases, it is severely impaired. So it's of note that the ultrasound, though providing interesting information, would not influence the therapeutical pathway, as I said earlier, that it only gives us that the congenital anomalies may not be isolated. So we look at the congenital anomalies of the kidneys, the ureters, the bladder, and then with the presence of Mullerian structures. So that the ultrasound helps. And in India, ultrasound is much easier to access and it's quite reasonably cheap. So there is nothing wrong in getting an ultrasound done. So let me get to the algorithm. So how do we go about? So if you have an undescended testis, whether it's unilateral or bilateral, first is look at whether it's palpable or non-palpable. If it is palpable, look at whether it is inguinal, ectopic, or retractile. If it is non-palpable, again, look at whether the testis is in the inguinal region, ectopic, non-palpable, or intra-abdominal, or it is absent. Now, this can be done only via a diagnostic laparoscopy. Ultrasound would not give us anything on this particular thing. Then if it is absent, it could be either agenesis or it could be vanishing testis. So the unilateral non-palpable testis, the most important thing is re-examine under anesthesia. If palpable, go ahead, do a standard orchiopexy. Non-palpable, look at whatever you want to do. It's a diagnostic laparoscopy versus inguinal exploration is still agreeable, but a diagnostic laparoscopy would actually give you the vasculature and the presence of testis. Subsequently, you can continue doing a laparoscopic orchiopexy, single stage or 2 stage, or you probably can actually shift over and then do a open orchiopexy. The testis is close to the internal ring. Go ahead and do an inguinal laparoscopic or inguinal orchiopexy. Too high for orchiopexy. Stage follows Stephens. How do you decide if the testis is sitting on the iliac vessels or there is very small mesentery, and if you can't pull the testis across to the opposite side? This is a very not a very effective method, but make sure that the mesentery is small and it is sitting on the inguinal, on the iliac vessels. This is a case for stage testis. Blind ending spermatic vessels, it's a vanishing testis. You need no further steps. You need not explore the inguinal region. There are significant number of times, about 30% you can see a nubbin, but they won't. There is no increase in risk of malignancy. And if the spermatic vessels are entering the inguinal ring, you can do an inguinal exploration, or you can still continue laparoscopically, where you can look at through the into the inguinal ring and then identify the testis. Okay, thank you very much.